So we're going to start Chapter 7's key points by talking about the benefits of using practice management programs to prepare health claims. So practice management programs increase efficiency by storing repeatedly used information in a database that can be accessed quickly. The major databases in these PMPs are the provider. The provider database has information about the licensed medical professional staff members who work in a medical office, such as their names, office addresses, and their MPIs, which is their provider numbers. The next database is that of the patient and guarantor. The data from each patient information form is stored in the patient guarantor database. These data include items such as the patient's unique account number and personal information, such as their name, address, phone number, birth date, social security number, gender, marital status, even employer, and then guarantor. The insurance carrier database is a payer database that contains the names, addresses, plan types, and other data about the major health plans the practice has participation contracts with. Next, we have the diagnosis codes, and the diagnosis codes database contains the ICD-10 CM codes that indicate the reasons services are provided. These codes are stored, so the codes that are stored are those that are most frequently used by that particular office, and additional codes can easily be entered and updates made annually as new codes come out. So they'll update annually as new codes are added or as codes are taken out of the ICD-10 manual. Next, we have procedure codes, and the procedure code database contains the data that's needed to create charges. So the the CPT codes most often used by the office are going to be selected for this database. And like the ICD codes, additional CPT codes are easy to enter or update if needed. And then lastly, we have transactions, and transactions are all the financial aspects of visits, so charges, payments, and adjustments. The transaction database stores information about each patient's visits, charges, and the related diagnoses and procedures, as well as received and outstanding payments. Okay, moving on to electronic and paper-based claim transactions. So there's some information here that you can read, but what you need to know is that the CMS-1500 was for many years the universal health claim, meaning that it was accepted by most payers. It's a very familiar red and black printed form. It was typed or computer generated and then mailed to payers or mailed to insurance companies. The method of sending claims changed with the increased use of health information technology in physicians' practices. And HIPAA, with its emphasis on electronic transactions, has essentially made the use of IT mandatory because of the law that states that practices and facilities, healthcare facilities, have to be using EMRs. So HIPAA requires electronic transmission of claims except from very small practices and those that never send any kind of electronic healthcare transactions. Only these providers can still mail or fax paper claims. Otherwise, electronic transmission of the HIPAA claim is mandated for all other physician practices. So it has to be submitted electronically, and there are only very few circumstances in which they can still mail a paper claim. The CMS-1500 form, there's a lot of information here for you. The CMS claim form contains 33 item numbers or information boxes. Numbers 1 through 13 refer to the patient and the patient's insurance coverage. The information is found, that information is found on the patient information form and the patient's insurance card. Numbers 14 through 33 contain information about the provider, the patient's diagnosis, or diagnoses if there's more than one, procedures performed, and then charges for the services. And that information is often located on the patient's encounter form. You need to read through pages 150 through 161, I think, are the pages in the book that cover the CMS form in its entirety. And then also you'll be working on these forms when you work through Connect and do your claim form practices. All right, so the HIPAA 837 claim transaction. The HIPAA claim contains data elements that are structured in the 5 major sections of the HIPAA 837 transaction. And these 5 major sections include provider information, subscriber information, payer information, claim information, and lastly, service line information. So this organization is efficient for electronic transmission rather than for use on a paper form. And these elements are structured in the 5 major sections that are listed here. So the levels are set up as a hierarchy with the provider at the top so that when the claim is sent electronically, the only data elements that have to be sent are those that do not repeat previous data. For example, when the provider is sending a batch of claims, provided data are set all at once. Provided data are sent once for all of them. If the subscriber and the patient are the same, then the patient data isn't needed because it's the same. But if the subscriber and the patient are different people, then information about both of them will be transmitted. So the 4 types of data elements that you should also be aware of here, there's required data elements. And that for required data elements, the provider must supply the data element on every claim, and payers must accept the data element. There's also required, if applicable, data elements, and these are situational data elements that are conditional on specific situations. For example, if the insured differs from the patient, then the insured's name must be entered. The third one is not required unless specified under contract. These elements are required only when they are part of a contract between a provider and a payer, or when they are specified by state or federal legislation or regulations. And then the last type is not required, and these elements are not required for submission and or receipt of a claim or encounter. So next we have the 3 major methods of electronic claim transmission. So practices handle the transmission of electronic claims with 3 major methods. The first is the majority of providers use clearinghouses to send and receive data in correct EDI format. Then the second is in the direct transmission approach, providers and payers exchange transactions directly without using a clearinghouse. And then lastly, some payers offer online direct data entry, which is DDE, to providers, which involves using an internet-based service into which employees key the standard data elements. So a couple of things to know about this slide. The majority of providers use clearinghouses to send and receive data, and so that's the majority of providers and offices and hospitals and anybody else that provides services to patients. The majority of them will be using clearinghouses. Under HIPAA, though, clearinghouses can accept non-standard formats and translate them into the standard format. So clearinghouses must receive all the required data elements from providers. They cannot create or modify data content. After a PMP created file is sent, the clearinghouse correlates, or I guess maps, the content of each item, number, or data element to the HIPAA 837 transaction based on the payer's instructions. So when the PMP has sent the claims, a report provides a summary of what was sent. And then later on, the receiver will send back an electronic response showing that the transmission was received. As far as DDE, point here for you. To note, DDE involves using an internet-based service into which employees key the standard data elements, like we said. So although those data elements must meet the HIPAA standards regarding content, they do not have to be formatted to standard EDI. Instead, they are loaded directly into health plans' computers. Just a couple of things to note there. Okay, so the process for billing secondary payers. Secondary claims are submitted after the primary payer issues an RA, which is a remittance advice, detailing how the claim was processed. So with the RA, we get the RA back and it tells us how that claim was processed, how much we're going to be paid out, or what level of payment we can expect for that claim. Once we know what we're going to get from the primary payer, then we can bill the secondary payer. So then secondary claims can be submitted electronically or on paper with the primary remittance advice. When the primary payer handles the coordination of benefits, which is abbreviated as COB, the practice does not submit a claim to the secondary payer. So a couple of things to note here. The practice has a schedule for transmitting claims, such as daily, could be every other day, but whatever it is that they have set up, they follow that. Claims are then received and processed by the primary payer, and that's the plan that is the patient's primary insurance. And then they will send back that RA, which details the reason for payment that is made. So when a patient is covered by more than one health plan, the second and any other plans must be sent claims. These secondary claims, and sometimes there's tertiary claims, which are the third claims, report what the primary payer paid on the claim. This fact is used by the secondary payer to calculate what, if anything, its payment obligations are. So, for example, if I have two insurances and my primary payer pays $75 on my $100 claim, then my secondary insurance should pick up the remaining $25 of that claim. But they won't know what they're supposed to pay out until they get a claim submitted to them with a copy of that RA to show what the primary insurance is going to pay out. So that's kind of how billing for secondary payers works in a very brief nutshell. Okay, so you want to make sure that you work on those claim forms for Chapter 7. I believe this is the chapter that the claim form practice starts with, so definitely work on those, work through the CMS form, and make sure you are reading through the section in particular in your textbook. I think it's, again, page 150 to 161, that talks about all of the different sections of completing a CMS 1500 form. All right, thanks, guys.